Yeah.
Okay, let's continue with the session. The next presentation will be held by Associate Professor Velinov, and he's going to talk about the venous stenting in idiopathic intracranial hypertension.
Hello, everyone, again. A rather interesting topic that, to be honest, in neurosurgery, I would say solves many problems after many years. Patients with idiopathic intracranial hypertension and pseudotumor cerebri are patients that suffer for years with headaches. What are the characteristics of pseudotumor cerebri? Raised intracranial pressure, absence of space-occupying intracranial lesions on imaging, and elevated CSF opening pressure of 25 centimeters in lumbar puncture usually, and normal CSF composition. These are patients that usually suffer for a very long time. I have to be honest that during my training as a neurosurgeon, I've seen too many of these patients ending up with lumboperitoneal shunts or VP shunts, and then revisions, and they suffer, they lose vision, and they can hardly work. Despite the low incidence, I have to say that these patients, if you can help them, they are very, very thankful for treating such a long-lasting disease that they have. Usually young obese women have a 20 times higher risk. Incidence is relatively low. And increased production or decreased absorption of CSF usually is discussed, and in the current scenario, what I'm trying to show today, that the increased pressure gradient in the venous sinus system can lead to a decreased absorption of CSF and leading to this type of pathology and increased ICP. So this is the mechanism. Everybody, I think, is more or less knows how it works, and where the CSF is usually produced in the choroid plexus epithelial cells, and then there is absorption in the arachnoid granulations and other places. So hypothetically, if we have venous sinus stenosis in a sinus transversus, having the venous drainage compromised, you would have increase in the intracranial pressure due to a malabsorption of the CSF. So this is something that has been, I would say, recently a very hot topic in endovascular. I saw this for the first time in Montpellier with Vincent Costelat, who is actually doing a lot of these patients. And if you look into neurology, you will see many patients that have tinnitus, and they have let's say, they have been treated for this type of pathology for a long period of time. So clinical presentation is usually chronic generalized headaches, 75 to 94%. Visual complaints, almost 80% with reduction in visual acuity. We're talking about young people that cannot work, they cannot see right. Papilledema in 95% of these patients, and pulsatile tinnitus. There is the modified criteria. The first were the Dandy criteria in 85, and afterwards were adapted. And as I said, many of these symptoms I already told you. Usually, as I said, these patients end up in a long-term conservative treatment using acetazolamide with a lot of adverse effects. Or they go to surgical treatment where they would get a CSF draining surgery with a VP or a lumboperitoneal shunt, where you have improvement in symptoms, but in many of these patients, they still, you can see a reoperation, and this is due to the fact that VP shunts give problems. They even in children, we put a lot of VP shunts, and usually they end up with reoperations. We change them, we change catheters. So a lot of these patients tend to have reoperations, and you can see that they have about 8% complications and about 32 minor complications. With venous sinus stenting, the improvement in vision is much higher in headache and symptoms, and the complications in these patients are lower. So if you can find such a problem in such a patient, it is not in all patients. We don't see this in all patients with pseudotumor cerebri, but we should be looking for a problem on MRI for a defect of venous drainage, especially in the transversal sinus or sigmoid sinus. And if we find such a problem and you see that the venous drainage is compromised, you can consider doing angiography and measuring pressure in these patients. There is a lot of evidence-based data that is accumulating for this type of treatment. Despite controversial, more and more trials are coming and series are coming. So you could see that also already in a protocol for these patients for treatment, except for lumboperidural shunt, you have venous stenting. We have, as this is a very, very rare disease, we also have just several cases, but I would like to share them with you. So this is a 40-year-old obese woman with chronic headache, diplopia, and tinnitus, who presented with visual loss and papilledema, 5 to 6 diopters. Lumbar puncture revealed opening pressure above 25. And you can see on the MRI the lesion in the defect in the venous filling in the transversal sinus on the right side. And usually this is what you should be looking for. It's difficult to see. You don't see this always on the time of flight MRA. You have to be looking at contrast enhanced imaging, and you look for defects in the transversal sinus or sigmoid sinus. And here you can see also this lesion. You see that the transversal sinus and the sigmoid sinus are pretty different in size. Of course, in this patient, what you need to do is you need to measure the pressure. And what happens is usually you have to pass through the stenosis, and you use a microcatheter in order to measure the pressure in the superior sagittal sinus. You can measure it in the transversal sinus before the stenosis, and you measure it below the stenosis. And you should have a pressure gradient above 5. If it's more, even better. In this patient, it was 10. But in Montpellier, they say if you have pressure gradient above 5, you can treat this patient, and probably they will have you will have a good result. I think there was a yeah. Do I press for the videos here or? Yeah. So this is the stenting procedure. This is a wall stent, 8 by 40, and usually what is important is that in these cases you try not to balloon. You can, if there is a problem with the stenosis, this is a dural duplicature, so this is not a vessel. So if you balloon, the chance of having a subdural hematoma is pretty high. So according to literature data, you could wait, and actually these usually the stenosis will open. So in both cases, our clinical outcome was pretty good. The major problems are, of course, stent thrombosis, stent migration, or proximal stenosis. You measure the pressure, and there is immediate drop of the pressure gradient after you put the stent. This is control angiography after 6 months in the patient. And visual improvement, reduction of papilledema. As I said, these patients usually have long-lasting problems, and they are very thankful, because if you solve the problem with a headache of a patient that had headache for 10 years, usually they are very, very thankful to you. Our protocol usually is control MRI on 3 months, DSA 6 months, of course. That depends on the patient. Second patient was a colleague, a pediatrician in our hospital, 34-year-old, who came with chronic intense headache, dizziness, vomiting, papilledema, and she was using acetazolamide for a very long time. Again, we observed this defect in the venous flow in the transversal sinus. I'm sorry, but here, because this case was a long time ago, I don't have all the images, but our solution was, again, a wall stent in the transversal sinus in the stenosis. And as I said, the clinical symptomatic is in these patients. Usually, if your indication is correct, they have a immediate reduction of headache, and it is important to have a pressure gradient. If you're treating a patient that you have a stenosis and there is no pressure gradient, probably the problem is not there. And this is the DSA after 1 year, because the patient did not want to have, did not want to have angiography for a very long period of time, and the stent is patent, and it's very interesting in these patients because in venous stenting, I mean in arterial stenting, we do have some protocols regarding antiplatelets, but in venous stenting, I have to be honest, it's very difficult to decide when to stop antiplatelets. We kept her for almost a year on double antiplatelets, then moved to single antiplatelets because the thrombosis of these type of stents is pretty high. This is, after all, a carotid stent in a venous structure, and the flow is low. So it's an interesting topic that I would like to hear your opinion too. So in conclusion, this presentation is just to the people that are not so familiar, or mostly I would say neurologists actually, that have tinnitus or headache or pseudotumor cerebri. It is an interesting pathology, and the treatment in patients with pseudotumor cerebri where we find venous sinus stenosis is etiological, which means that in very few patients with this type of pathology we can say that we are treating etiologically the disease, and this patient can be long-term in good condition. You cannot expect 100% resolvement of the symptoms, but I would say that 60-70% of, let's say, reduction of headache is more than enough for them. As I said, there are complications and we have to be careful, and thank you for your attention.
Thank you, Dr. Velinov. It's very interesting, and like I mentioned, if I may add, we continuously start to include more and more procedures in your everyday practice, so it's impressive, very interesting. Is there any questions from the room?
To be honest, there is no, I think for venous stenting, there is no protocol. In both of our patients that it happened, I stopped in the first patient on year 2, and I observed her clinically. But for 2 years now, we have an MRI, and I would suggest that in this type of patient, I don't have a clear protocol or opinion to say. I was afraid to stop it before, but after 2 years, she's fine. We did 2 angiographies now, and stent is patent. We reduced to single antiplatelet, and now we stopped it because she has adverse effects of the clopidogrel, and she asked me just a couple of weeks ago, could I stop the antiplatelet therapy, and I said yes. But as opposed to arterial stenting, here I have to be honest that it's very difficult to say. What is your protocol?
We are keeping the dual for 1 year and then single, more or less into the day, but they would have complications that you can be
Yeah.
them to stop as well.
Yeah.
Normally it should emphasize much earlier actually, so normally it should not cause a problem.
Yeah.
Thank you. Some other questions or comments?
Maybe a quick question. How many patients do you see? I mean, for me, this is quite rare disease. I mean, I have only a few of them in the last 10 years. So,
It's very few, but I have to be honest, if you're looking for something, you find it. I was for a certain period of time with Kostelat, and I saw he was having a very good collaboration with neurologists, and actually they have a very large number of patients where they have tinnitus, and if you look into these patients with tinnitus, you will see that actually there are a lot of patients where we're just not looking into, and they have a lot of complaints. I can tell you that hearing a noise during your work time could make you go to psychiatry. So I guess that in these type of patients, you just have to collaborate with the neurologist, and the neurologists have to know that this thing can be helped endovascular. And I think this is exactly the point that if you don't know this, they are treated by neurologists conservatively for years. We put in pseudotumor cerebri shunts. Yeah, Professor.
Yeah, no, just a simple comment about MR. MR is, of course, very important, and usually, most of the times, that it will show the problem. But sometimes it looks normal.
Yeah.
But if you have the typical symptomatology, I would go the same for angiography and measuring the pressure, because you will find the gradient, even in cases where MR was normal. And of course, there is something there which is abnormal, and then you need to treat also these patients. So even if the MR is normal, but the symptomatology is clear, I would go for...
I absolutely agree with you. Yeah. Yeah.
Dr. Velinov, there was a very recent controversy about the headache getting worse after venous stenting. And then the publication, and actually the guys found out that this might be related to the extent radial force of the carotid stents. Have you seen something similar? Do you think the wall stent is the perfect stent here, or do we need to like expand for a new stent that is more compliant to the venous part of the cerebral circulation?
I don't have the sufficient experience for that. The wall stent was the, let's say, stent suggested by Costalat in Montpellier, what they were using. And I believe that this could be possible reason, because if you stretch the dura and the duroduplicature, of course, they will have a lot of headache. But in general, could be possible. In my two cases, they had reduction of acetazolamide and headache almost immediately. And the first patient who had 10 years of acetazolamide, she, of course, it was a bit longer until she had the reduction of symptoms, but she has stopped all the acetazolamide, and she has some residual tinnitus. But yeah, I guess also sizing here is important. Yeah, Shandior.
If I may add, I think at that point they have a stent which is venous dedicated. Bosman stent, I think, was the name.
Yeah.
So maybe I'm not familiar with the properties. Maybe the properties will address this issue.
Yeah.
Budapest, we have a case series of about 13 sinus stenting since we started the program. And we do see sometimes headaches, but it's always temporary. And when we actually use these headache questionnaires at 6 months, and basically it is disappearing, and you're getting just as good results in headache resolution as you would with the original shunt surgeries, but you're having much less complications with the stenting. Another important thing I think that we have to highlight is not just neurologists have these patients, but also ophthalmologists should know about it. Because what we have seen as problem, and we do have a lawsuit, luckily not suing us, but the referral hospital, is that if you referring your patient with papillary edema that would tend to chronic, then the visual symptoms will not improve so much. So that's why actually we should raise the awareness of ophthalmologists of this treatment being available, because if you do it too late, then probably the visual symptoms will not improve.
This is always the protocol that you have to see if there is atrophy of the optic nerve, then probably, as you say, you're already too late. That's true.
Let me enlarge the spectrum.
Yeah.
Not the ophthalmologist, not the neurologist, ENT physicians. If there is a tinnitus, we need to inform them.
Yeah.
Let me tell you the common fault is MRI is not enough. Contrast-enhanced MRI is somehow. Contrast-enhanced MR venography should be the protocol for patients, especially with vascular tinnitus, suspicious vascular. Otherwise, we already missed a bunch of cases up to now that still we're not doing proper radiological images.
Thank you.
Thank you. Thank you, Dr. Velinov, once again. So our next speaker